Okay. Welcome everybody to this very interesting topic on the Coffee with Clinician series. This topic is going to be dealing with some of the items which, as biochemists, we are very passionate about. That's about dyslipidemias. I don't think there's any medical profile which doesn't, or any patient who's visited the hospital who doesn't get his lipid profile tested. So in today's session, we're going to discuss about the lipid profiles and the implications, or the way the clinician sees the reports and manages his patient. So this will give us an insight into what is happening on the other side of the patient based on the reports that we're generating, how we can help clinicians manage their patients better. With me, I have a very illustrious set of panelists. We've got Dr. Sanjay Raina. He is the professor of the Department of Internal Medicine in Amrita Hospitals. Welcome, sir. Sir, can't hear you, sir. Your voice is...
Yeah, it's nice to be part of this meeting, and we look forward to a very interesting discussion.
Okay. I also have with me Dr. Navreet Singh, or should I say Brigadier Navreet Singh. He's my batchmate, and we joined AFMC together at the same time. Arguably one of the best cardiologists in India.
Oh,
If we look at his posting profiles, he served at all the Apex Army hospitals in the armed forces. So welcome, Brigadier Navreet.
thanks, Harit. You're very kind. Kind with your words.
Okay, and we also have with us Dr. Monica Kakkad. She's the additional professor and dean academics in AIMS Bathinda. Most of us in ACCLMP know her pretty well. So I think we've got a decent number to start. Ma'am, welcome. Now, once again, audio.
Good evening, everyone.
Good evening.
We have a hope we have a great deliberation today.
It is going to be interesting, because a lot of interesting stuff is going to be discussed over here. To start with, let's get the ball rolling. Yeah. When we were taught classically as undergraduates and postgraduates, we used to insist that 12 to 14 hours of fasting is required for doing a lipid profile. And the wisdom of that was that we are estimating LDL cholesterol by the Friedewald's formula, and we didn't want the kilomicron, so we told the people to fast for 12 to 14 hours. Madam Monica Kakkad, madam, is this still true to be?
So interestingly, actually, we working at AIMS Bathinda, essentially a tertiary care center. The first question is, how are we going to really ensure, are we really able to ensure that the patient is fasting? One.
That's a very good question.
So again, it is, we are purely depending on the patient's feedback. If he says it's fasting, we take it as fasting. The other thing is, another school of thought thinks, if anyhow, normally the patient is not fasting that long, then we should be assessing their status as what it exists physiologically. So I was just going through literature. The clearance of triglycerides is something like 8 to 10 hours. So practically throughout the day, we are actually not fasting. So is it good to actually assess them the way they normally, the physiological processes are happening? So, and of course, the feasibility in tertiary care centers ensuring, patients coming in fasting samples would be difficult. Besides that, I think rather than, we concentrating on viewing them as complementary, we should be looking at, they should be treated as complementary rather than taking them as in exclusivity. So we should be looking as in whether we require, the lipid profile assessment to screen a population, then probably non-fasting would be a good choice. So now many recommendations are actually supporting non-fasting samples as well. So yes, but then if under certain conditions, when we want to see that okay, there is, we have to start a drug which will lead to hypertriglyceridemia, definitely we should go for fasting. When we are starting maybe steroids, or definitely, I mean, our clinicians would definitely have a take on that. So with that, and if the patient is giving a fasting, why not? But otherwise, a lot of places, their consideration is there, and we have literature to support that also, that we can still go in for fasting samples, because essentially it affects the triglyceride levels. Otherwise, yes, there are things in others like total cholesterol, HDL levels, but that those are not as significant as PT. So if we are looking at total cholesterol levels, maybe fasting would be a good choice.
So in a non-fasting sample, triglycerides get affected. Is there any other parameter which gets affected in the lipid profile? I know the other parameters are affected by the pre-analyticals.
So as I said, majorly triglycerides, others do to a lesser extent, but majorly it is TG.
Triglycerides. Okay. So Dr. Diana,
Yeah,
what is
yeah.
a random testing?
So basically, if we look at the guideline, it is now talking about non-fasting lipid profile as the guide for treatment. So the requirement for it being strictly fasting is not there. Plus, when we say fasting, what do we really mean? Because even if you have an overnight fast, still some reflection of the last 5 days meals will be there in the triglyceride. So strictly fasting would be that you are having a very routine food for the last 1 week, rather than so we can't really go there, because that would not be practical to do. So most of the guidelines have done away with the fasting requirement, and they are talking about a non-fasting sample basically.
Okay, so yeah,
I,
Dr.
I just have a question. Sometime back when you take non-fasting samples, that upper part used to become whitish. Now,
lipemic samples.
yeah, so that makes no difference now.
No, lipemic samples, we'll be touching upon it down the line.
Okay.
Lipemic samples is actually a kind of dyslipidemia straight away, because normal people, from my experience on fasting and non-fasting samples, I find that between fasting and non-fasting samples, there's about a 20 to 25 or 30 milligrams of milligram per deciliter of triglycerides, which are slightly different. Apart from that, I really don't get to see much of them. And from what I understand is that your goals of treatment is not directed towards triglycerides, but more towards the cholesterol. So there is an issue about whether we really require fasting. But then, ma'am, madam, I have some question to ask you. Universally, as what the clinicians are suggesting, and it's a practice in the common lab, that whether you're fasting or non-fasting, you are getting non-fasting samples. Does the biological reference range of triglycerides in fasting and non-fasting samples, are they different, or are they the same?
So they are different. Now the recommendations are, if it is a non-fasting sample, then greater than equal to 175 should be taken as a cutoff.
Okay.
Vis-a-vis the normally for TG we take it as 150, so we can consider. But at the same time, having said this, more than 500 would still, I mean, that is still a thing of worry. But below that, we should for the TG levels, the cutoffs are straight less than equal to 175. So anything greater than 175 would be taken as a thing of worry.
As per ma'am, you got some references for that, ma'am?
Yeah, I can share the references where, and I think even certain labs have started working on creating separate services, wherein if the fasting sample is, because if we have lab information systems, the reference ranges tend to directly reflect in the reference side. So you can have different services which are meant for fasting and non-fasting samples, which would give the reference ranges considering the
Okay. Rana sir, would you have any, is your teaching slightly different about the levels of non-fasting triglycerides, or you agree with ma'am on that?
No, the
Isn't it a difference?
levels are as per the same that ma'am has quoted, and they are the levels that are used as a reference. But The treatment targets, because as she said that it's only when it's above 500, we are really worried about it. And we really do not target the triglyceride as such unless there is a compelling indication to target triglyceride. Because we are more concerned with the cardiovascular risk rather than with the number of triglyceride by itself.
So it gets to the other question that supposing a person in a non-fasting sample came with a triglyceride of 250, would you advise them to come back the next day on fasting to actually see it, or it doesn't make a difference to carry on types?
No, well, from a treatment point of view, it doesn't make a difference. What we would do is that we would control the other risk factors, go
Right.
down the line, repeat the sample, say after 2 or 3 months, and then look at it again.
And if the values are still high, it doesn't matter whether fasting or not. That
It
would be
doesn't
discontinuing as such.
matter unless it comes into the more than some people take 300 as a cutoff for treating, and most people will agree that above 500 it's a risk factor, so we have to treat above 500.
Brigadier Navneet, anything on this?
No, I think he's absolutely correct. Triglycerides, even up to 250, 270, 300, if there is, if the LDL cholesterols are less than 160, ideally around 130, and the total cholesterols are less than 240, I would be very chary in starting drugs specifically for the triglycerides. I would start it to bring the total cholesterol and the LDL cholesterol in the normal limit. So triglycerides solely won't drive me unless it costs 399, 400.
This is a very important point that I want to share with all the people who are there with us in this discussion today, that when we are talking about fasting and non-fasting and the kilomicrons, calculated LDL is history. Most of us are doing direct LDL, so this point goes straight away. Even if you calculate it as TG by 5, that further brings the lower down. And as for the clinicians, I said, they're not going to be alarmed even if it's going over 300 or let's say 250. So I think it's about time we re-look at ourselves and the way we were so passionate about non-fasting lipids, fasting lipid samples. And I think we should adopt a more patient-friendly approach of saying random sample for lipid profiles is good enough because it's not going to really affect the treating window. Am I okay in making the statement, sir?
Sure. That is absolutely correct. What we are more worried about when we are talking about the samples is the lab-to-lab variability in the results. Because many times we get patients, in fact, yesterday I got a patient who tested simultaneously within probably an hour or so at 2 different labs, and he got a difference of about 50 mg% in the cholesterol level. So he was like kind of confused. Is that the real cholesterol level, or is this the real cholesterol level? So what we as clinicians are more concerned about is the standardization that we are using, and how do various labs they come across as far as the standardization of the level is concerned.
So that would be more of a question on quality assurance, and this is the clinical interpretation of the results. We assume that the quality of the report of my lab is very good, and we're looking at how the clinicians are going to react with that. But this is something interesting. I'll catch you up tomorrow 1-to-1 and we'll follow up this case. Right.
Sure.
This brings us to the next question of VLDL, because personally as a biochemist, when I've been working, the test that we do for, we don't have any test for VLDL. We do total cholesterol, we do HDL cholesterol, we do LDL cholesterol, and the difference of them is the VLDL cholesterol we are calculating. And since there are 3 different tests with 2 different protocols, there are times, especially when the cholesterol is low, you get mathematically VLDL in the negatives, which is quite a ridiculous thing to talk, but it does happen in the lab. Monica, madam, have you ever faced this?
So normally what we do is we do not report that, because that's not, it doesn't make sense reporting that way. So if you have direct LDL facilities, VLDL basically, why are we looking for clinicians, sir, would probably be able to comment
That's the
on
next
that.
question.
It's not taken as a treatment, thing for treatment. For what disease states are actually considering VLDL levels. Only thing is,
Does VLDL ever come into your protocol of treating patients?
No, it's not. It's non-HDL is still there, but not VLDL alone. No, certainly not.
So I would like to chip in here because when we are talking about the cardiovascular risk, we are talking about all atherogenic molecules. And separating the atherogenic molecules does not help much. So a non-HDL cholesterol is a much it's a good thing to do because it includes all the atherogenic molecules. And another one which probably you will take up further is the ApoB, which is a
Yeah,
representative of all the.
I'm leading up to that question. I'm leading up to the question.
Okay.
So do I take it for granted that VLDL means nothing? Non-HDL cholesterol means a lot, but VLDL cholesterol as such means nothing.
Because we are not going to treat it in isolation. So probably it is not relevant from a treatment point of view. From a biochemical and from a research point of view, it may be important to look at that independently.
Now, here's where the question comes that when I get a negative VLDL, the algorithms to evaluate it's because of some interference, is it because of hyperproteinemia or something? There are a lot of other things which do. That is an exercise to generate a value which doesn't help the clinicians. So supposing I were to say that let's do away with VLDL in the report, would that create any ripples?
I don't think so because none of the clinicians is really looking at the VLDL value as far as treatment is concerned. But definitely from a research point of view, if you're getting a negative value, that means something is off somewhere. And we really need to look at that what is it that is affecting the values, because that may be impacting some other parameters also at the same time. We are concerned about this in Asians because Asians have a lot of atherogenic cholesterol. So VLDL is a very important component of that. So how we are really looking at that, it's a very good research question actually.
So supposing we give you the non-HDL, we give you total cholesterol, we give you HDL cholesterol, LDL cholesterol, and non-HDL cholesterol. So all the atherogenic components have been there with you. So would that be okay?
That is good enough for treatment purposes. Yes.
Okay. So there's a lot of biochemists there in this group right now, and this was an important take-home message for all of you, because there's been a lot of debate in the ACCLMP chat about the negative VLDLs. So this is what you're hearing from the cardiologist and the professor of internal medicine. So we can really rethink about what we're doing. So now that brings us to the next question, leading up to the ApoB and ApoA ratios. How do they help you in the management of patients? ApoA and ApoB estimate, because that is a test which is on the immunoassay platform, and since it's not being universally asked, people are not doing it. So is that anywhere in the algorithm of managing patients?
I don't think it is anywhere in the algorithm of managing, simply because I suppose the accessibility factor. But otherwise, of course, B associated with LDL and A associated with HDL. That's, it makes sense. Ratios make sense. But I think if you have HDL and LDL direct measurements, then it makes a lot of sense. But if you have indirect measurement of LDL, that's where the ratio becomes more.
Indirect is practically gone off in most of the labs. I mean, if you call it a decent lab, everybody is now going with the direct LDL.
Then I suppose ApoA and ApoB ratios won't be so significant. Well, I don't know whether ApoB is 100 and 48. I have no idea. But I suppose if you are directly measuring LDL and HDL, more or less the guidelines and the biochemical cycle, if you think of it, the body should be good enough.
Rana sir, any opinions on you?
What I believe right now is the problem is that we don't have studies to have a standardized reference for treating based on these parameters, because all the guidelines they are talking about LDL cholesterol or they are talking about non-HDL cholesterol. They are not at all talking about ApoB, because as we say from a biochemist point of view, you would say that ApoB is the ideal marker because it gives you the atherogenic potential. However, it's a long way because there's no standardized values and no standardized guidelines as far as the treatment would be based on ApoB levels. So we really don't know how to use that information, although many labs are reporting it. I don't think it is really being used to guide any changes in the management.
Sir, let me rephrase the question for the benefit of clarity for everybody else also. Leave economics, leave availability. HDL cholesterol versus non-HDL cholesterol is 1. ApoA and ApoB is 1. So if I were to give you any of these parameters, what would you choose?
ApoB, because ApoB is the sum of all the atherogenic molecules, plus a single value would do away with so many confusions that would be created, because you look at LDL cholesterol, you look at triglycerides separately, you look at HDL separately. So it would be a unifying value, and if we could base our treatment guidelines on ApoB, that would be great. But we are a long way from there, because we don't really have the studies to really go there.
And
Okay.
pardon
Yeah,
me, ApoB is a conglomeration of B48, B100s and all those? Or is
Yes.
it
B100. We're
All-
looking
all
at
Apo,
B48 to do
B-
with the chylomicrons. We would be looking at ApoB100 because the antibody is against the ApoB100, and that's how we quantify it.
okay? So chylomicrons are out.
Chylomicrons are out.
Yeah, then that would not be representative of all the atherogenic. So we need to have all the ApoBs together. Then only we will be able to really think about this.
Okay.
I would think the other way, because chylomicrons to liver tak hi सीमित हैं.
Gee.
Of course, unless of course it's a very majorly fed state. So I think then that's why B100 has been targeted specifically. But I don't know, sir. मैं पढ़ना पड़ेगा. I have to read.
So, this is not a theoretical discussion. This is like what you face with your patients every day. You've got a long history of treating patients. So, for you, the HDL and the non-HDL is good enough.
True. For day-to-day practice in everyday OPD, I think HDL, non-HDL is good enough.
Okay, so that gets me to talk to all the biochemists in this group that the lipid profile, we generally talk about total cholesterol, HDL, LDL, triglycerides. It's just a mathematics to do non-HDL cholesterol. Total cholesterol minus HDL cholesterol is non-HDL cholesterol. Please include that in the analysis. It's going to be increased the reporting. So that gets us to the question is, we were talking about the guidelines of NCEP guidelines. Ma'am, broadly, could you just tell us like what do we as biochemists understand about the NCEP guidelines? And then there's another guidelines also which is done, that's the Lipid Association of India guidelines. It's something proud because there is a guideline which has got the Indian name to it. So could you share the criteria and then we'll talk the traditions, how do they use it to manage the patients?
So, basically, as part of the lipid profile, so we are the NCEP guidelines, or be it the Lipid Association guidelines. We take into consideration total cholesterol, LDL, HDL, and triglyceride levels. Besides that, non-HDL levels are also the recommendations have been given, but majorly just total cholesterol, LDL, HDL, and triglyceride levels. Now, between the two, essentially the recommendations are the same. The only thing I think Lipid Association of India, considering the Indian makeup, they have made the LDL cutoffs very stringent. Now, that would be clinicians take whether it is warranted or not. But the only difference, otherwise, be it total cholesterol cutoffs are the same, like less than 200, 200 to 239, more than 240. So similarly for others also, less 40, 60, low risk, high risk, as in case of HDL. TG, again, it is 150. Less than, it should be less than 150, then 150 to 199, 200 to 499, and then 500, more than equal to 500. when it comes to LDL levels, since it is the major thing we are looking for when we are treating patients, the Lipid Association has made those cutoffs very stringent. So when we say less than 100 is optimal, then 100 to 129 would be near optimal, 130 to 159, 160 to 189, and more than 90 is high, 190, sorry, more than equal to 190 is high risk. When it comes to Lipid Association, the cutoffs are much more stringent considering the risk factors. So if they're associated risk factors, then it will be, if they're acceptable, then less than 130. So it is basically starting at the optimal level of the NCCP guidelines. So then less than 100 if the risk factors are increasing, less than 70 if they are high, and very high, less than 50. So if you are at very high risk, then the values have to be maintained at less than 50 compared to the NCP guideline, the Indian guideline. So that is in the crux, the major difference between the NCP and the Lipid Association.
So what I kind of guess is that the LDL and the HDLs don't change. The LDL cholesterol, the Lipid Association has brought everything down by 30 milligrams. So say that with people with high risk, you're looking at an LDL cholesterol of about 60 milligrams per deciliter as desirable. Sir, high risk. So, sir, your take on this?
Yeah, the value that the Indian Heart Journal, some publication was there.
Lipid
So the
Association.
value is 55 for LDL cholesterol, less than 55 for high risk. And there is a category that they have included, which is very high risk, which has recurrent CVD, that is less than 40.
Okay. Can we target such low LDL level and the patient will be all right?
I believe there have been studies, including some of the newer drugs, which have sort of targeted patients to these levels. And the consensus for these people who have recurrent events is that the lower the value, the better it is. So that is how the recommendation has come. We don't really know if there are any other effects on other systems which would come out from such low cholesterol levels, but that is what the recommendation from the point of view of preventing any further events in these patients who are at very high risk, because that is the major mortality risk that these patients are having.
I have seen people in Vedanta with total cholesterol 50 milligram per deciliter, and I actually jumped out of my seat and said, but then I got used to seeing this kind of reports, but then it really triggered me out. Do people really have a normal quality of life when they are targeting such low cholesterol? Brigadier Navneet, any experience in such low cholesterol levels?
So I think the major effect of low cholesterols is more of theoretical, but the effect of the drugs does creep in. Say a 40 milligrams or 80 milligrams of atorvastatin for a long time, you find approximately, I would say, 25% coming back to say that they have some amount of muscle pain, asymptomatic rise of liver enzymes. So there are there, but I think in cases of very high risk or high risk, it would be a fair call to put them on a higher dose of statin. It's a fair call. You can now you can add fibrate, or you can add in our cases fibrate specifically because it also lowers the triglycerides a little bit. But more so you can have bempedoic acid. It's got a sparing effect on the total dose. So you can now have combinations to get it down. But I think if you ask me specifically, low cholesterols, very low cholesterols, I've done it in maybe 2 or 3 patients who had recurrent events, recurrent officers who had recurrent events. Not really low cholesterol, they come back with drugs that, sir, it's I can't jog any longer, I have muscle ache. Of course, their enzymes are elevated. So I think those are more of the effects than specifically, increased malignancy and all that. I don't think At least I have not seen all that.
So we are really concerned about the other end of the spectrum. What happens most of the time is that you have the patients and they come in with elevated cholesterol levels, and then they are started on high dose statin, say atorvastatin 40 or rosuvastatin 20, and then everyone forgets about it. So the cholesterol comes down to say 140, 130, and no further treatment is being added. A large proportion of patients are there which are inadequately treated as far as the guideline goes, because we have patients with multiple risk factors: diabetes, smoking, alcohol, and family history of CAD, premature CAD, who are not being treated to target. That is one of the major issues that we are facing, because clinicians just they say that we have started a statin and that's it.
Okay. So
And we are
what
super responders. I always make it a point, we are super responders. You'll find 20 milligrams do wonders, far much more than what it will be in a white man, or
Yeah.
I would say the Chinese descent. They are there, but Indians per se, we are bad at cholesterol, but we are super responders also. So I think that's a saving grace.
That's a saving grace. Good. So what I kind of understand from these discussions right now is that probably the low cholesterol is not going to be actually a problem, but it's the side effects because of the medication that one should be more worried about. And in people who are at high risk, it is better. It's more desirable to keep the cholesterols low to prevent recurrent events. That's what I understand from the take-home message, sir.
Yes. I would encourage a person to go on to take higher doses even on the second or third visit, because at least in the educated population, they would read about it and then try to correlate major of their symptoms along with the side effects, and then come back and say, oh no, I'm on this. Sure, I think you need to do something. The number of patients coming back with side effects in the last 10 years, or maybe post-COVID, because we started reading more after COVID, is much more. Pre-COVID,
COVID, I'm going to touch COVID slightly at the end of it. Okay, let's now view it from this side. That if a patient comes to you, if I give a report of total cholesterol 220, 320, and let's say 420. Three figures I'm giving you: 220, 320, 420. The triglycerides are all right. How would your treatment to these patients change? At 220, I'm going to initiate treatment.
Okay, so I would initiate treatment. I think probably certainly the treatment in 420, 320, maybe give him a chance. Lifestyle measures, I don't know. Even a small lifetime measure to take it for that amount of life is very difficult. It is, just to change from 2 chapatis to 1 chapati, or just to start, it is not possible. I mean, I have really not been able to convince somebody. Of course, fat people thin, but normal, it's very difficult to say कि zindagi bhar abhi aap. So after an event, they'll do it maybe for 6 months, 8 months to go off alcohol. In Punjab, where I practice, the 3rd month he gets his wife along to ask me, may I be allowed alcohol now? How long will you stop him? I would say at 220 or 320 or 420 in our country should be started on drugs. The dosage, maybe this thing, the frequency of testing would be more frequent for the 320, and the addition of a second drug may be quite much more relevant.
Sir, what about you, sir? What's your take on that? Same.
If we look at it from the beginning, so at anyone who has turned 18 should get a cholesterol level done.
Okay.
And then from there, we take it according to the cardiovascular risk. So practically speaking, if we look at the guideline, almost everyone will be on statins.
Yes, sir. You are very right.
We really have to think that if you can always offer treatment. What I do in my practice is that I tell them that, you need this as a treatment. I can offer this. Then you have the choice to decide whether to start a drug for cholesterol itself or not. Obviously, if there are medium risk or high risk, then we will tell them that this is absolutely must and you have to take it. But for low risk individuals, it's always a patient choice that do you want to be on drugs for cholesterol, or you would rather do something else, do lifestyle, whatever you are motivated to do. So because if we go by the guideline, then almost anyone above 18 would be getting statins.
Okay, that's what the guidelines are for. Anyway, so the choice. So when would you actually, beyond what value of cholesterol, let's say, would you say that okay, this guy has to be put on statins?
No,
220.
this is more about cardiovascular risk rather than about the value of statins, value of cholesterol. So I would really want to stratify the person as far as cardiovascular risk is concerned. And
Okay.
if he is a low risk person, then we can
delay.
really wait upon the values, because the values by themselves do not do much. It is the cardiovascular risk defined which is more important.
Okay, so the take-home message for all of us is that it's not the cholesterol value that actually determines when the treatment is going to be done, but the risk factors also that play a major part in deciding whether the person should be put on drugs or not.
And the age of the person also.
So that will also come in the risk factor, right?
Yeah.
Okay. Now, let us say that here's a patient who has a cholesterol of, let us say, 320. Let's start off with 320. When I start a treatment, the statins, okay, now the question comes is, when do I check up for response? Is he responding or not? Or when do I at what level do I start deciding, no, maybe I need to step up the drugs? So first we'll answer these two questions, then I'll come to the complications subsequently. So when I put a person on statin, when is the next time am I going to see his lipid profile to see whether he's responding or not? What will I define as not responding that will make me increase the dosage of medication?
So there are two aspects to this. So when we are talking, let's first talk about the low risk category. So in low risk category, if we have started, then we can wait up to 2 months also. Although the recommendation is that we do it at 4 weeks and see if there's a 40% reduction. So if a 40% reduction has happened, that is good enough for that particular drug. And if we do not meet the targets, then we can add further drugs to that. That is for the low risk category.
40% reduction in a span of 2 months.
In a span of 4 weeks.
4 weeks, one.
In 4 weeks. Okay, sorry, 4 weeks. Okay, very good. And in the high risk?
In acute coronary syndrome, we would go ahead and do a combination, probably. Dr. Navneet will be better talking about this, that we often in acute coronary syndrome, we would want to go with a combination of statin plus estimate to begin with.
Yes, that's coming in as a big way, but I don't know, sir, for you saying low risk and high risk, I would think anybody who hasn't had a cardiac event, who only has risk factors, I would probably give him 3 months to after putting him on. But if you've got a cardiac event, any cardiac event, or if he's diabetic, or if he's got CKD, then I would think, yes, let's go down and do it every 6 weeks or a month. But earlier than that really is, I mean, I don't know what the guidelines, to be honest, but as far as I read the guidelines, it was 4 weeks to 12 weeks. But if you're saying 4 weeks, you may be correct. I think unless you have had an event, I won't be that rapid, maybe 12 weeks.
I totally agree with that. If we do not have risk factors, then 3 months would be good enough. And for acute coronary syndrome,
I think a month. You're right. You're right. A month. And ezetimibe has been now propagated, and there are a few trials which have recently come in that suggest that yes, it is. But in isolation, ezetimibe has not been,
only as a combination.
As a combination over the statins.
Majorly because the statins were in acute coronary syndrome, you would start with very high dose of statins. So it had a little sparing effect. That means instead of an 80 atorvastatin, now you would give it a 40 plus. That is
Yeah. So
that's
and what they found in a couple of studies is that the reduction with even a high dose statin is around 8% or 9%. And when we use a combination of medium dose, that is 20 rosuvastatin plus estimate, then it is around 15%. So the combination probably has an advantage over the even the high dose statin. And obviously it has got the benefit of reducing the side effects.
I thought it was higher. I thought it was about 40%. But if you're saying, I think that the cholesterol lowering of high dose statins in most it's 15%. I don't know. I thought it was higher, much higher.
No, not the cholesterol lowering. It's the benefit, the mortality benefit.
Oh, okay.
I'm talking
Yes,
about.
yes, for sure. I thought the cholesterol lowering.
The cholesterol reduction with high dose statin may be between 25 and 40%.
40%. Yes, yes.
Okay, so now the point is that there are a lot of statins in the market. The choice of statins, is it defined by the cholesterol level? Is it defined by economics or by the clinician's choice, or a combination of all of them?
So basically, if we look at it, there are three major statins that we see today. One is rosuvastatin, which is water soluble. There is atorvastatin, which is lipid soluble, and then there is pivastatin, which is a less effective statin. These are the three categories that we are looking at. So as far as the guideline goes, there is not much difference between rosuvastatin and atorvastatin, only that rosuvastatin milligram to milligram is half of the atorvastatin dose.
Okay.
So I would try both, give both, and because in the armed forces we are providing either, the Jo mil gaya. So we just switch, and the patients are now quite confident kiska half lena, uska double karna. I don't think it's got any effect. I don't think the lipid profiles have changed much. Maybe some report less with rosuvastatin, but I don't see it. I mean, there are some reports.
Both of them are equi. Both of them are equi, and there is no guidelines to say that if it's about this, then use this or that. It is individual choice, availability, and those are the factors which will come into play.
True. Very sure.
Okay. So now we get down to the complications of treating. One, I know that myopathy occurs with statin therapy. Okay, and is there any other complications that you are worried about?
I think asymptomatic and symptomatic elevated enzymes. Enzyme elevation is there. I can be saying that on few occasions we found patients, especially in Punjab, you start them on a statin, you see them after 6 weeks, their LDL, their SGOT-PT are elevated, and then you get an ultrasound done and you find that they have cholesterol or they have gallstones. So finally, after consulting you, they go to get their gallbladders removed, which is like, so I think by way of enzymes being elevated, asymptomatic is the majority, 20%. Nearly 20%. May not be the doubles on the into 10 part, but at least doubling would be there, or less than doubling would be there. If 56 is a cutoff, you would be having 76 or 78.
Okay.
Myopathy. Yes.
You're saying something, Navreet?
Myopathy, by way of enzymes, very few cases I can point on. By way of elevated of CK. I think 2 or 3. That too, you can attribute it to dehydration, running in the heat, and all those in the soldiers. So really, I don't know how much is Sir noticed, but myopathy, symptomatic myopathy with enzyme elevation, not much.
So when we are talking about these symptoms, so we have two aspects to it. One is, as Sir has said, symptoms, that is muscle related symptoms, and the second is an enzyme elevation. So we really have to sort of dig it out whether the symptoms are really due to myopathy or they are attributed to something else. So it would be very pertinent to correlate the two, the enzyme elevation and the symptoms, because a lot of patients are having just the symptoms, and very few are having symptoms plus enzyme elevation.
So then two questions. When do you actually think that the medication should be stopped? Number one. And because the myopathy was very severe to warrant a stop, that it goes clinical, does it go biochemical? And the next question is, what alternative do you have if you have stopped the statins?
So you take it. I mean, first of all, immediate stopping, I have never done till date. Never. I don't think in any patient I've ever stopped it, because it is like overwhelming myopathic, almost like myositis or something. Nothing. Never.
Okay.
Reduce the dose by 50%.
Okay.
Do a lipid profile after 4 weeks. See the symptomatic benefit. If not, if the lipids are high, add another drug.
Okay.
If your lipids are very good, which is on most occasions the scene, actually, you will find that even on half-in dose, after 1 month, the lipids are good, you reduce it by further. I mean, you come down to 10 atorvastatin. And majority do stopping. I don't see it ever that I've had to stop it. I don't know what.
I agree with Dr. Navreet, because from a cardiovascular point of view, there is no stopping the statin.
Sir.
And if we do not have cardiovascular risk to that level, then probably what we would do is that we would stop the statin for say 2 weeks and then reassess and restart. The only case scenario where we have to absolutely stop and not give statin would be somebody who has landed up in rhabdomyolysis, which is extremely rare.
Okay. So then, so all the hype about myositis because of statins, we got a clear picture that's actually really not going to stop the treatment of it. Just maybe you reduce the dosage and most of them get away with it. So wonderful. Now this gets to another question about the two ends of swinging spectrum. I have seen people with HDL as low as 5. Does that make you jump out of the seat? Number one, and what would you advise these people? First, let's start this, then I'll come to the next question when the pendulum goes the other way around.
I would actually ask the biochemist that HDL5, is it really there? On occasions, we get very low HDLs, 10, 15. But I think my treatment would be still driven by LDL and not by HDL. So HDL low, in fact, I mean, now even the upper limit of more than 60 has been removed as a factor equivalent. It has been removed. But HDL so low, ma'am, I don't know how many, how would you explain?
We get it quite, not very often, but once in a while. 10, 15, though I get it. Okay, 5.
Even in not in cardiovascular events though, but in ICU settings, sepsis patients mein HDL levels, you can get very low HDL.
But sepsis level mein cholesterol is an acute negative stress marker, so you're not supposed to do lipid profiles in ICU patients. That just goes out straight away.
Those values are seen.
Seen. Okay, seen. So
So,
you got some.
how I would look at it is that whether the low HDL is part of a generalized low lipid levels, or is it in contrast to the other lipids. So this would be a very important distinction to make, that if the total cholesterol itself is 70 and then we have an HDL cholesterol of 5, it would not be surprising. But if the total cholesterol is above 250 and then we have an HDL of 5, then it would be very different. It would be very different.
Probably that's where the ApoB and the ApoA would come in much more handy.
So supposing a person actually genuinely had a low HDL, is there anything that you recommend to improve the HDL? Alcohol is one of the best things we say, which is it's just peene wale ko peene ka bahana chahiye, okay, by that.
So as far as drug treatment is concerned, we do not really recommend. There's no recommendation for any drug treatment for low HDL levels. Yes, lifestyle, obviously, exercise is beneficial, and drug treatment is not indicated for low HDL levels.
What happens if the pendulum swings the other way around when you get somebody with an HDL of, let's say, 80, 100? Okay, then they say that there could be some abnormalities and all. So how does that swing?
I don't really think that we have any category of treating such patients, basically, because there's
Okay.
no recommendation on treating a high HDL or a low HDL per se.
Okay, so high HDL, is it a risk factor at all? Because I've heard people say that it is a risk factor and it indicates that there is some defect in the cholesterol ester transfer proteins or something like that. So that itself is a problem.
So I don't really know how it would, because when we are looking at lipids, we are not generally looking at the lipids themselves. We are looking at the potential of the lipids to cause atherosclerotic cardiovascular disease. So
Okay.
how that would affect atherosclerotic cardiovascular disease, that's not, because the high HDL would be thought to be protective. So it would not be correlating with what we are majorly looking for treatment of lipids. So in isolation, whether the high HDL requires treatment for any condition, we really don't know that.
And Dr. Navneet, what about you? How do you react to have you ever got anybody with the HDLs in the 80s and 90s,
Oh,
and
yes,
how does it
yes,
change?
yes, yes. I mean, till recently, an HDL above 60, I would send them home saying, "You're lucky. I have an HDL of 35. Go home, enjoy yourself." But of course, now they've removed that high HDL as a risk, as a negative risk marker. So I would still believe that a high HDL is good, because after all, it's in most settings it shows a good good cholesterol cycle. I think HDL, if it's elevated, I would still think it's a very good marker of good metabolism. So HDL, as much as it has been removed in the classification now, it would still be considered a negative risk marker.
Good HDL, good HDL, good thing.
Yes, even the Framingham risk score, I think, as a high HDL still is considered as a marker.
Okay.
It takes you away from the red to the yellow and the orange.
When we talk about dyslipidemias, the Fredrickson classification as 1, 2A, 2B, 3, 4, 5, that's only academic interest, or does it actually translate to patient management?
As far as the scenario nowadays is concerned, I don't think anyone is using that for because none of the guidelines mention that any longer. It's just the LDL cholesterol and the non-HDL cholesterol that is there in the guidelines. So I don't think anyone is really talking about those types anymore.
Okay, so all the passionate biochemistry teachers who have been torturing the first MBBS students with Fredrickson's classification, this is a wake-up call. Okay, that brings us to another lipid, which is a lot of talked about but less done. That's LPA, ApoA.
So when we are talking about lipoprotein small a, so it's an independent risk factor.
Correct.
For atherosclerotic cardiovascular disease, and it is desirable to bring it down. I think probably sir will agree. The normal level stands at something like less than 50,
So,
but there are no treatment targets yet defined, and there are no FDA approved therapies for lowering LPA.
yes, I totally agree. So I totally agree. You're talking of lowering of lipoprotein. Yes, no real method has been this thing, though it's a glaring marker for sure. And
So, the couple of drugs, the newer drugs, the injectable ones, they do reduce the LPA by about, I think, 20%. But there is no FDA approval for using these drugs just to decrease the LPA.
But then from the lab point of view, while we know that the test is very good, we don't really get so much demands of the test. Is it lack of awareness or what?
It's
Because
mainly because none of the guidelines has yet mentioned that this be used as a marker for treatment. So unless we have drugs that are specifically targeting LPA, and we have guidelines saying that the LPA should also be looked at and should be brought down to that level. So we really won't have too much activity on this front. Only if we come out with some guideline on that, then only it will be. Although we as Indians, we know that we are having this problem more than the Western population of having a high LP small a. So, but really there is no guideline saying that this should be targeted and it should be brought down. Although they do say from a metabolic point of view that it's desirable to have a lower level, but
I
treatment
don't know how
target
to bring
has not
I
been
don't know how
defined.
to bring it low, so there's no point giving a number and saying you got a problem and I can't do anything about it.
Yeah, lipoprotein small a is more of a marker telling you that yes, you're at high risk for coronary artery disease. But I don't think lowering of any, how do you lower it? Sir is saying, I don't know, PCSK9 or inclisiran.
PCSK9 and inclisiran do have effect of lowering, but the treatment has not been defined. It has not been approved.
Is that the same story with the small dense LDLs? Because there's a lot of talk about small dense LDLs also being a cardiac risk, and there are kits to do it, but then there is no ask for those tests. You don't ask, I don't do, you don't ask, and you're in this vicious cycle.
I think it's got an effect. And last I read, diabetics were known to have more of the denser LDLs.
Small dense LDLs, yeah.
So I think anyway, if you're a diabetic more than 10 years, you're anyway going to high risk. So sometimes I even go to the extent, if you're more than 10 years and a diabetic, whether you are as good as a person with any heart disease, and just start the drugs full house. So they form a real bad category. Something which I've found missing is that many of the renal failure CRF patients are not on statins. And it is difficult to convince them, convince the nephrologist to say, okay, I think it's a major risk factor. Let's act on it. So I think that is one field. Diabetics, yes, certainly we have started to increase more and more, and now it's nearly everybody universally gets it. But not renal failure patients, not peripheral arterial disease going to surgery. So that is one population group I found that they are not on statins at all.
There's some echo coming somewhere. Can everybody please mute their mics? Yeah, thank you.
So I think two categories where I would think, my colleagues are listening, that renal failure patients and peripheral arterial disease, because most of them go to the surgeons or they go to a nephrologist who OPD where they are not so increasingly started on statins or lipid lowering as such. So I think that's one category where we need to really focus a little.
We've actually extended the 1 hour, so I'll just finish it up by two quick questions because they were there in the list, and one question from the audience. One is, what do you do when a triglyceride is about, let's say, 450, 500? Okay, the sample becomes milky, right? So I'll ask from you, sirs, what do you do for treatment of such patients?
So if we look at it, the primary indication for treatment of isolated high triglyceride would be to lower the risk of having acute pancreatitis, which is 500. So we definitely want to lower it. And for that, we would be using the fibrates. So primarily, if somebody is already on statins and still has got high triglyceride, then an addition of fibrate would be useful. There is a case for use of eicosapentaenoic acid also, because some cardioprotective effect has been attributed to only that one, not the other fish oils. So probably that would be an addition if somebody would want to use that. But primarily use of fibrates to decrease the triglycerides. Now, the treatment target for triglycerides is still a debatable issue. It's not yet been defined how much lower the triglyceride should be brought to look at a decreased risk of pancreatitis. From a cardiovascular point of view, probably there's not much that the lowering of triglycerides will have on the cardiovascular mortality. So,
Very true, sir. Very true, sir. So I would start a fibrate and be on the lookout of the slightest extent to start a statin. I think a fibrate without a statin just doesn't fit the prescription. Initially, you may give a fibrate, but I would still be on the lookout. How could I add a statin?
yeah, probably if you go down the line, these patients, because I've been following such patients, so at some point in time, 2 years, 1 year down the line, they would be on a statin fibrate combination.
Yes.
Okay, so eventually, whatever it is, these people with hypertriglyceridemia eventually come down to fibrates and statins together. Last question for the thing. The list is very long, but I have to cut short this whole discussion. Ma'am, post-COVID, have you seen any change in the lipid profiles? And after your statement, we'll ask the clinicians, what do they feel about it?
They would be better to talk about it, but generally I think the lipid profiles, I mean, I went through the different studies, also the meta-analysis also, because COVID was one time where there was uncontrolled data being coming, and really not there was no way to actually check the authenticity of the data, because COVID itself was a big name. But still, having said this, I think meta-analysis do suggest that there was increase in LDL levels, the total cholesterol levels, and there was decrease in HDL. I don't know. That's what we used to generally see, but as a post-COVID sequence, I mean, this and that study, the meta-analysis, what I am referring to, it is a good number as well, published in Lancet. So we were also observing certain these kind of changes, but I don't know if our clinicians have that same take on the deranged lipid profile. But for us, yes, we were observing at this study also. That's a Lancet study, around some 50,000 patients were considered COVID, who suffered from COVID, and compared to those who did not. So that's a robust study, but I don't know if you have observed the same.
I don't know. I mean, I've not read the study. I'm sorry, but from a personal experience, I think what COVID only majorly brought health into focus. So many people started doing the lipid profile much more frequently, and that is one major thing that we've gained through COVID. By way of COVID itself, I think long COVID could probably scientifically affected by causing some elevations of inflammation. Inflammation being a HSCRP and CRP and the changes. But scientifically thinking, once you're over with a viral illness, I don't see, unless there is ongoing inflammation, that you should really think that it will worsen lipid profiles over such a long period of time. Scientifically,
I don't know, as part of post-COVID sequelae, after after COVID is gone, now are there the little changes in the baselines as well? Not really.
Is there any experience for you about the lipid profiles
I would agree with Dr. Navreet that it is the COVID. What it has done is it has sort of focused things on health. Second, that there is some increase in inflammation that has been there. However, as far as we say the lipid profile guidelines, there is no guideline which says that if you have suffered from COVID or not suffered from COVID, there is no change in the treatment targets. There is no change in the levels. So it is really not made any difference as far as the treatment of patients is concerned.
Dr. Prajwal has asked a question, and this is probably a personal experience, that LDLs are almost non-detect. Very sorry. He found a case which was LDL was almost non-detectable when the patient was in statins. quality controls all in place. Have you ever come across such a situation?
No, I've seen LDL cholesterols over 20, but I've never seen undetectable LDL. Never seen a report like that.
Okay, Dr. Prajwal, that's something very interesting. We need to follow up that case on a one-to-one basis. Is there any role of insulin dextrose infusion in lowering triglycerides? This was asked by Dr. Mareshwari N.
When we are looking at lowering of lipids, it's a long process. We are not looking at acutely lowering it. And as far as triglycerides are concerned, because there's no mortality benefit data that has come from lowering it. So we don't really look at acutely lowering the triglycerides. So treatments which work in the acute setting would probably be more of an academic interest rather than have a real impact on patient management.
Very true. Very true. I think
This discussion doesn't seem to be finding an end. So I'm constrained to thank all the participants, sir, Rana sir, Navreed, Monica ma'am. Thank you very much for participating in this. It's really taken us to different levels of understanding the lipid profile, what my report means to the clinicians, how the clinicians manage. One major take home that I have in this discussion is that all the panics about fasting versus non-fasting triglycerides is gone off the window, because the treatment goals is at 300, 400 plus, and we are fighting about 20, 30 milligrams. So that's something that we need to rethink. Monica ma'am has been kind enough to share an article which says that for academic purposes, on the report you can put that non-fasting triglyceride less than 175, and there's an authority to link up to your report. So that one has also come out over here. Plus the statins and the myopathy was something which, any biochemist would say statins, myopathy, CKMB, AST. And now we find that the clinicians are saying we have no reasons to stop the statin. At best, maybe we will lower the medication. So there are a lot of things that we had misconceptions as a biochemist working in isolation in my lab. And there's a lot of things that we can understand when we interact with clinicians and they understand us and we understand them better. A lot more questions were there, but for the paucity of time, I have to cut up. And from my deep of my heart, I really thank you all for your participations. So any closing words from your side, Rana sir?
Thank you, Dr. Harith, for such a wonderful session, and really it was very interesting to sort of discuss all these issues, because some of these issues are very close to our day-to-day practice, because day in and day out we have patients coming with these, and a lot of patients have a lot of different questions regarding this. So really very thankful for such a wonderful initiative. Thank you.
Okay, Navreed, some words.
Yeah, thanks, Harith. I think fantastic. I mean, is the word. And thank you so much for such an interaction. Made me revisit a few articles, read a little bit. Yeah, that at this age you really need to be poked to read. And but what marvelous questions from the audience. And I'm so happy that you brought physician, a cardiologist, and a biochemist on the same table. Otherwise, we hardly see each other. And
Believe me, you get to see us more often than not for the way you've been talking to us. Monica ma'am, anything?
So first of all, thank you so much. It was a wonderful interaction, and I think as a biochemist, tomorrow when we go to the labs, probably all this discussion would make things more meaningful for us when we are looking at those numerical values. We know how they are going to get interpreted in real life. So that was a wonderful interaction. Thank you so much for giving me that opportunity, and everyone have a wonderful evening now.
And a good word of thanks to all the audience. We had more than 120 in the session going around. So that's a huge number and it's going to pick up. So thanks a lot. Till we meet again with the next set of clinicians, with the next coffee with clinicians. Thank you very much. See you.
thank you so much, sir. Thank you. Thank you, sir.
Thank you, sir.
All of you can leave. I need some time for that recording to stop and all that. So you could leave